Bismillah ar-Rahman ar-Rahim. My name is Dr. Kamran Shaikh, and I'm a consultant psychiatrist working in the UK. So today's topic is about the Tourette syndrome, and we have covered the the assessment uh, in the previous lecture. And in this talk, we'll try to cover the treatment bit, which is the biopsychosocial aspects of treatment. Are my slides visible to you?
Yes, they are visible. Thank you.
Okay. So the last time we covered the course and prognosis, course and prognosis. So tics uh, range from mild to severe and tend to stabilize over time. So that's the prognosis. And the tick severity symptoms, it improves by early to mid adolescence. Uh, and then the social functioning may be impaired. And it is when the social functioning is impaired, or if the tick severity is too complex. In that case, we need the medical treatment. And even then, we start with the psychological treatment. If it doesn't work, then we go on to the medical treatment. So, rejection by peers and anxiety, having tics in social situations, and tics may impair academic and occupational functioning, and by their disruptive impact in class or interference with violent head and neck tics, which may cause physical complications such as compressive cervical myelopathy. And that's where we start treating it. So the next is the treatment bit. So the treatment, so individuals with mild to moderate tics do not need any treatment, especially the medical treatment. They may need the psychosocial treatment, but not medical. But once it becomes disruptive in their day-to-day functioning, then you start treating them. Okay, and the first step is proper education of the patient. So psychoeducation is the first step of treatment in any condition. And that's why in the cask stations, and we have cask candidates here as well. Uh, so in the cask station, psychoeducation is as an important bit. And similarly, in the Pakistani FCPS OSCEs, psychoeducation is very important to do, and that is usually therapeutic, and it benefits. So who can you educate? You can educate the patient, the family members, and teachers, and those who interact with the patient. So it could be other far relative or friends of the patients, or any other carer, etc. So the first line of treatment of mild to moderate tics is cognitive behavioral treatment, or cognitive. But this is CBT is modified CBT, so we call it cognitive behavioral intervention treatment, CBIT, instead of CBT, which is cognitive behavioral therapy. So it's a modified CBT. And medications are only used when the symptoms are significant and they are unable to be addressed by psychotherapeutic interventions. And so the first criteria to medicate is that are significant and severe. And secondly, so the symptoms themselves are interfering and with the academic or job performance. And secondly, the stress related to the symptoms is causing uh, much more disturbance in the person's psychosocial environment and or academics or school or job performance, so peer relationships, social interactions, or activities of daily living. And that's where you will start treating, especially when the symptoms are severe. So the treatment is generally individualized and tailored to the needs of the patient. So the most distressing or impairing symptoms are targeted first. So even in the CBIT, you target the most troublesome symptom, which is causing problem. For example, if eye blinking is causing most problem, then you cover that and you start treating that first. You ignore the other things. So you can make a hierarchy and then start with the most distressing symptoms, treating the most distressing symptoms. So it is it is opposite to the other behavioral intervention gradual desensitization in phobias, in which you start with the easier thing first and then you go to the most difficult. But here it's not desensitization. So it is something like the habit reversal. So you start with the most interfering habit, which is causing problem. So the goal is not to eliminate tics, but to relieve tic related discomfort or embarrassment, and it can lead to some degree of uh, lead to some degree of control to function normally. So the person may get back in their own control with the situation eventually. So that is the goal of the treatment. And now the next slide. So cognitive behavioral intervention, or so clarification of to the patients that the patient's symptoms are not completely voluntary. So what happens is that the family start blaming the child कि ये तुम्हारी गंदी आदत है, it's a bad habit of you, change this habit, why are you doing it again and again? And that is very distressing for the child's self-esteem. So what you need to say that to educate the parents as well as the child, it is not completely voluntary. So that means that there is an involuntary component to it, and the child should be given benefit of that. Then use of a tick room or a timeout. Again, compared with the ADHD, what you do with the ADHD is you you give them time out to discharge their hyperactivity, to discharge their fidgeting. Fidgeting मतलब होता है कि उंगलियों को जो है वो हिलाना, असाबिया यानी fingers, you're just moving your fingers or your toes or anything. So you're fidgeting constantly. That means, so that's what you need to give them time to fidget so that when they are sitting in the classroom, they are more attentive. Because my theory is down in my explanation in the uh, in the brown fonts, that there is a psychic energy. That's what Freud and others of that time talked about, psychic energy. So that psychic energy needs to come out. So you let that come out. So that's why you send them to the tick room. Sometimes if they go to the toilet, they can discharge their ticks in the toilet or in a private room. Timeout area provides an opportunity to contain problematic tricks and or compulsions and to destimulate. So they discharge their ticks, or in ADHD, they discharge their hyperactivity during that period. And I will request later Dr. Enamul Haq Khan to give a lecture on ADHD. And of course, our respected Professor Nasir Said Khan Saab has also given, and he will teach us more about the stimulants and their use. So, relaxation techniques. So, again, my theory is that when you are using the relaxation techniques, what is the phenomenon behind the progressive muscle relaxation? So anyone would like to answer? What is progressive muscle relaxation?
Sir, in progressive muscular relaxation, it is the autonomic nervous system stimulation, especially the parasympathetic part.
Mm-hmm.
That's what I. So
Yeah.
usually we get stressed up with the sympathetic activity is,
Mm-hmm.
it has its overactivity. So to counter that, it stimulates tenth nerve, and that that the parasympathetic nervous system is doing pretty much the opposite as to sympathetic nervous system.
Mm-hmm. Very good. Yeah. So what we are doing and psychologically, what we are doing is we are tensing the muscles and relaxing them. And I have an anecdote to tell you with this relaxation technique. Just came to my mind that a person was going into a boat and he was crying, "Oh, I'm too scared, I'm too scared. Oh, मैं मर जाऊंगा, I will die. I'm going to die. Oh, save me, please." So the whole, all the passengers of that launch, they were getting disturbed by his agitation and by his fear. So what they did was they put him into water, and three times they dipped him into water, and then brought him back to the boat, to the ferry. And when he came back to his launch, then he was quiet throughout the journey, because what they did was they introduced flooding. So they exposed him to the most kind of fearful and the worst come scenario. So after they exposed him to the tense situation, he got relaxed. That's what we do in progressive muscle relaxation. We expose those individuals to to the more stressful and more tense situation. And when they are exposed to that, then what happens is that when they come to relaxation, they start feeling relaxed. Now, how does it relate to this tic disorder? In tic disorder, when we do these techniques, So in progressive muscle relaxation, it will, what is the isometric tick? Can anybody tell? What is the isometric ticks we covered in the last lecture? Anybody? Number? What is isometric contraction? If you remember your physiology.
Cannot recall isometric ticks.
Okay, isometric means that the muscle, I also didn't know until I relearned last week, so don't worry. So isometric means that that the muscle length does not vary, and there are some tics in which the muscle length does not vary. For example, if you are tensing the abdominal muscles, so you are performing ticks and no one can see those ticks. Similarly, if you're tensing your calf muscles, no one can see. And it's isometric because the muscle length is not changing. You are providing minimal contraction. So it does not uh, provide you a significant increase in muscle length through that contraction. It almost remains the same. That is isometric. So that's what you do in the progressive muscle relaxation. You are producing isometric tics, or by definition, you can't call them tics, but you're producing isometric voluntary contractions, and that will release the psychic energy behind it. So when that energy is released, you are performing tics or movements yourself, and when you are discharging all those movements yourself by doing the progressive muscle relaxation, you're letting the energy go, and when you're relaxed, then you won't have that much urge to perform tics, and especially in the social situations. So it is better to perform the relaxation exercises when you are alone, or discharging tics when you are alone. And then when you go to the public, you can be tick free for that interval of time. So that is the importance of relaxation techniques. Are you clear so far?
Yes, sir.
Okay, so so that's deep breathing also in the, so that was the once when I was describing was a kind of progressive muscle relaxation. That is the use of relaxation tapes. That's usually of progressive muscle relaxation. But the other relaxation techniques are also helpful because the stress worsens the tics. So if you are providing deep breathing, it will relax the patient, and when the patient is relaxed, they can be tick free. Okay, similarly, guided imagery. So the guided imagery, and that's what we do in the progressive muscle relaxation. We combine all three: deep breathing, guided imagery, and progressive muscle relaxation. And I hope that all of you in Pakistan must have learned these techniques from your senior. Am I right?
Yes, sir.
Yeah, yeah. So basically, so deep breathing relaxes you. Guided imagery is that you just imagine, like, deep breathing is take deep breaths, and guided imagery is that just imagine that you are in a seashore, you are at a healthy place, and there is a cool breeze going on, birds are singing, and it's very pleasant weather. It's not too cold, not too warm, and now you are taking deep breaths. And then guided imagery, it also says, like one British Pakistani psychiatrist told us, that you write on that beach with a small stick that worries, or you write the biggest worry, and then you imagine that the tides of the time or the tides of the ocean come and wipe that out. What you have written on the sand, the tides will come and it will wipe it off. So in the same way, your worries will be wiped off by the tide of the time. And that's a great reassurance. And it is realistic when we talk about the tide of the time. When it comes to the tide of the ocean, it doesn't seem realistic. When we talk about the tide of the time coming and taking off your worries, that becomes more kind of realistic in that situation. So, so that we were saying that psychic energy needs to come out, progressive muscle relaxation, safe discharge of tics when alone or in the tic room or timeout room or at home, and discharge more isometric movements. Because the individuals with tic disorders are already doing that. When they are aware, when they come into their teens, they know what tic to perform when and how to escape or evade embarrassment related to tics. Okay, so CBIT, habit reversal therapy, awareness training is the first thing. So what are the triggers? And then the second thing is developing competing response to the targeted tics. So tic substitution. So substituting with a more kind of socially acceptable or tolerable tic. And then performing whenever you are getting the urge to perform the tic, you do something else instead of doing the actual tic. Instead of eye blinking, you start, either you can open your eyes fully, so that is the habit reversal. You're doing the opposite movement, or you are doing a substitute movements. You start moving your toes in a closed shoes instead of moving your eyes in a social situation. That's kind of habit reversal therapy. Parental and child training and relaxation training. So the parental training is also very important in all childhood disorders, whether it is autism, whether it is ADHD, whether it's anything. So when it comes, parental training programs are important, and different voluntary agencies run these programs in Europe. And sometimes the health services have contracts with those agencies who will provide that, and then the government pays the health agencies, and then the health agencies pays those NGOs who provide this training to the parents. So and sometimes health professionals on their own, they are trained and they are paid extra for providing these training. Contingency management. Uh, Anybody who knows what is contingency management mean?
So it's more like token economy, right?
Exactly, exactly. So can you explain it a little bit more? What is token economy? Just explain
Like when a child does anything, the desired task, then he is given a gift in the form of
it.
money.
Absolutely. Yes. Yes. So
So
that's what
the
you
desired behavior is encouraged.
exactly. Yeah, and that's what in Pakistan a term is used, operant conditioning in that regard. So that's what we do,
Yes.
and of operant conditioning or behavioral therapy. So token economy you can do. Yeah, if you don't discharge takes during that, well, you can't eliminate the takes forever and for 24 hours, but you can say that this is a social situation. For example, guests are coming to the house, and if you don't discharge any ticks in the presence of guests, you will get a bar of chocolate. And if you do, then you won't get anything. So, and you can discharge as many ticks now before the guests coming, and then that's kind of token economy, so you can do that. Social support and relapse prevention. So you just support the parents as well as the child, and relapse prevention techniques. Once you have treated the person, don't leave them alone. Provide them with some kind of weekly or monthly support and ask them how they are doing. So psychotherapy. Now, other than that, that was the CBIT or habit reversal therapy. So psychotherapy is a kind of individual, group, or family therapy. So it's again similar to psychoeducation. And for an individual person or for a group of patients, it is to restore and maintain the self-esteem and promote mastery and coping. Family therapy is extremely useful because the family members are often they are very much distressed, as I was saying in Dr. Nasser's lecture yesterday, that the most stressed families are of the opposition defined disorder individuals and the conduct disorder children. Their families are the most stressed. But even now in Tourette syndrome, the families are a bit stressed, and it is important to provide them with family therapy, how to cope with their children. And uh, what we were discussing about the parental training is the same. Family therapy, what's the difference between family therapy and parental training? Anybody? I'm trying to make it interactive. So even if you're wrong, just say something.
Sir, in family therapy,
Mm-hmm. Mm-hmm. Yes.
more than one members or other family members are involved as well. But in parental therapy, obviously both the parents of the child
E-
are involved.
Spot on. Exactly. That's the thing. So the brothers and sisters, or housemaid, or anybody, or carer, or if the child is living in a care home, so anybody who is involved with the children is involved in the family therapy, apart from the primary caregiver, which is the parents or guardians. So the guardians could be foster mother or adoptive mother. So they will come under the parental training. But when it extends to the siblings, it is called family therapy. And family therapy is used when there is a disturbance in the interaction between the siblings as well. So it's not only with parents. Then that's the time when you use family therapy. and uh, and then after that it comes the group therapy for parents. We have already discussed parental training workshops. Never ever blame the parents that they are bad parents, and one of the things they are guilty. And in the cask stations, we're going to the cask, the parents will ask, am I a bad parent? Why do I have to get the parental training? And actually they are actors and they are told to ask this. But in OSCEs, and you have learned through the part one of the or the intermediate module of the FCPS, that never ever take the any role player as a role player or actor. Treat them as real parents and real patients. So they are distressed. So what they say is, am I a bad parent? They feel guilty. So you have to address that guilt in the very first setting in any parental training. That no, it's not, you are not a bad parent. Sometimes your child is having an illness and he can be difficult at times and difficult to cope with. We will teach you the tips, जिसको पंजाबी में कहते हैं टोटके, या उर्दू में भी टोटके कहते हैं, कि हम आपको टोटके सिखाएंगे, हम आपको तरीका सिखाएंगे. Will teach you the tips how to deal and how to cope with with your child. And you do the psychoeducation, plus you teach them the tips and techniques how to cope with your child in the best possible way. For children, it will be social skills training. Again, with autism, ADHD, and in Tourette syndrome, you need to teach them social skills training, and so that they learn that what to do in social situations and what not to do in social situations. Okay, social, school and occupational interventions. So symptoms may interfere with their academic performance, and so that you also teach the teachers or employers of patients with tic disorders. If they're adults, you can just teach their employers. And so task-oriented structures in the classroom you create, preferential seating. For example, ADHD children, where should they sit? What should be their seating position? Anyone? Where in the classroom?
Can you please repeat?
Children with ADHD, what position they should sit in the class to get the maximum output?
Front rows.
Yeah, so quite close to the whiteboard or the blackboard, okay? Close to the teacher so that they can pay most attention. And where should a child with tic disorder without ADHD should sit? With no ADHD symptoms, perfect attention concentration, but has tic disorder. Just we are brainstorming. Where should that child sit? He has no control over his tics, but his concentration is fine. Any guess? I'm also guessing. I don't know the answer.
Sir, I don't know, sir. Sorry.
Yeah, I think, in my opinion, if they sit back in the class and if they can concentrate on the whiteboard or on the screen from behind, it will be okay for them to sit as a backbencher. So the what will happen will they can discharge their tics in a more easier when they are sitting back, and there will be less people observing him, and there will be less distraction to the other class members by his tics, as long as the tics are not vocal tics, if they are minor motor tics. So it's again preferential seating, but we will ask the child, and the child should have his say whether he wants to sit in the front or back and what will be better for him. So that's how we decide. One-to-one support and individualized educational or work plans, and flexibility is a key element in educational and occupational intervention. So you need to be flexible in everything, and timeouts from the class or work settings, and time limits may have to be extended or eliminated for exams. So sometimes people with diagnosed ADHD, and that has to be, uh, sometimes the false documentation or forgery can be present. So at least, like, let's say with ADHD, there should be at least two psychiatrists should certify that the child has ADHD. I'm just suggesting in an hypothetical situation, so that there is no forgery of the documents, and the child is attending the service for ADHD for such and such long time, so that there could not be any fraud or anything. And then the time limits may be extended for such children. Similarly, for tic disorders, severe tic disorders, who have to tick every now and then, and especially if their tics are related to their hands or arms, so they may need some extra time for their papers, for their exams. And again, that extra time should be strictly monitored, and the invigilator will be seeing, yes, the child is ticking, and they may be given 15 minutes extra or something. uh, Writing aids such as laptops, and tablet PCs. For example, if the child's handwriting is so bad due to developmental coordination disorder, handwriting difficulties, or their hands stick every now and then, so maybe they can write better with laptops or tablet PCs. And uh, I know a person who went into some postgraduate exams, and he had vision difficulties, squint or strabismus, and he used his laptop instead of writing in that exam, and he passed. And he is one of the top clinicians in his specialty now somewhere. So that's what we should promote. So individually tailored and adaptive education, structured tasks, organization of tasks into smaller units, and flexible time limits, ample physical space, etc. Medications, so severe and challenging cases only. And now we come to our really the medical bit of it. So monitor ECG in nearly all the medicated children. It is good practice to monitor ECG. And when I was doing child psychiatry, even for antidepressants, my consultant was saying monitor the ECG. It's not, with antidepressants such as fluoxetine in adolescent, it's not necessary, but it may be a good practice if you can monitor the QTC interval. At least getting a baseline, and then don't monitor if it is normal as a baseline. But with antipsychotics, it should be monitored. So, and similarly with the stimulants, it is a good practice to monitor, especially if because the stimulants they stimulate the heart and they cause tachycardia and high blood pressure. So if the child is already having a history, then it is must to do the ECG pre-hand in such ADHD individuals whom you are giving stimulants. Not in every children or every child, not in all children. So monitor ECG will be one thing, but here you are most likely going to give them some antipsychotics. So monitor ECG, body mass index. I have seen children blowing up even with aripiprazole. So aripiprazole, risperidone, they blow up the children. And that's why in smaller children, we don't even touch the olanzapine, because olanzapine will be even more detrimental than aripiprazole and risperidone. So BMI, body mass index, metabolic profile, liver function tests, TFTs, and abnormal involuntary movement scale, and start with the lowest possible dose, such as 0.125 milligrams of risperidone or 0.125 milligrams of haloperidol. So you have to start with very low doses. And when we think the next, we may cover something, the old age psychopharmacology, and we'll discuss the importance of this low doses then as well. So in children, it's due to their body weight and their size, they need very small doses. And also they are drug naive, so they didn't have any medications before, and that's also another reason to give them the lowest doses. Now, I won't go into the individual doses too much, but let's go through different medications. So clonidine. Clonidine is an alpha-2 adrenergic agonist, and clonidine activates presynaptic autoreceptors. Because it is adrenergic agonist, that's why it's a kind of, it has a stimulating effect, and that's why it can be used as not as a stimulant, as a non-stimulant, but it can be used as one of the medications in ADHD. Similarly, it can help with the tics. So It is an agonist, but it will reduce norepinephrine released and turnover in the cerebral cortex. So it also reduces the disinhibition, impulsivity, inattention, and hyperactivity. So that in a child with with comorbid tic disorder and ADHD, clonidine will be the ideal thing to give in that child. But now the data suggests that you can even give stimulants as well if they are tolerating. So pre-pubertal patients, that's what the term is used by the Kaplan and Sadok, uh, textbook of psychiatry. So pre-pubertal patient means children. So will generally need dosing 3 to 4 times daily. So clonidine is very short acting, and that's why you give it TDS to QDS. And adolescents or adults can be started 0.05 milligram daily. But in children, you start at 0.025, so 0.02 milligrams you start with, and then you go to 0.05 later. In adults or adolescents, you can start with slightly higher dose. And then maximum you can go in in adults or adolescents is about 0.45 milligrams. So the next, common side effects: sedation, headache, dry mouth, stomachache, mild sleep awakening. They are the most limiting side effects. Now, we as psychiatrists are very much afraid of hypotension. But as Professor Nasir Saab was saying that he does use clonidine for the children. And if we start very low and if we go with very, very minor increases, hypotensive effects should not be there. They're minimal in this dose range. But even then, you do measure blood pressure, pulse, and ECG. And in Ireland and England, and especially I worked in Ireland in child psychiatry, so the psychiatrists generally do not use clonidine because of the fear that it may cause hypotension. But in practical, that risk is not there to a significant extent. But I have given clonidine in Ireland only when the neurologist started it and we were continuing it. So that's how we wrote the prescription for it. And it was good. And so there is a transdermal form available as well. And long acting oral is also available. You can give it twice daily. Even the long acting is 12 hours. So you have to give it twice daily instead of 4 times. Now, guanfacine, again, the same mechanism of action. And you start with 0.25 milligram daily. There it was 0.025, and here it will be 0.25, so slight difference in the dosing. Go up to 3 milligrams. Side effects will be the same as clonidine. Now, antipsychotics are neuroleptics. So pimozide was used before. Haloperidol is still being used, and it blocks the D2 dopamine receptors in the basal ganglia, decreasing dopaminergic input from the substantia nigra and ventral tegmentum, thus reducing tics. So in very small doses, it will reduce tics. But in higher doses, what can it cause? Anyone from the audience? Yes? What side effects it will cause in the higher doses?
Sir, extrapyramidal side effects.
Yes, exactly. And if you are giving it for a long time, what extra pyramidal you will be looking at?
Sir, tardiness. dyskinesias.
tardive dyskinesia. So that's why we start very, very low, and in very low doses, it will help tics. Okay, so again, it will be given for according to the symptom severity and quality of life concerns. So we've already covered this. These are the side effects, and you already know them. Okay, neuroleptic agents or second generation antipsychotics are now the first line treatment. So risperidone or aripiprazole. Olanzapine is also helpful, but I won't give it because of the risk of metabolic syndrome. Because if aripiprazole is leading to weight gain, what about risperidone and what about olanzapine then? So, and especially the autistic children, they have a tendency to binge eat, and that's another thing. They can put on weight easily. And when I used these medications, that was in autistic children for their temper tantrums, and that's why they were putting on weight. And maybe it is more as compared to the children without autism. I don't know, but you need to be careful. So maybe aripiprazole may be the first line, or risperidone. So I don't know what child psychiatrists give in the UK. But when we did practice at that time, risperidone was more popular, that most popular, and now I hear that aripiprazole is the first line. Haloperidol again 0.125 milligrams starting dose, same as risperidone. Sulpiride, tiapride, tetrabenazine. Tetrabenazine also you can give, and it is a non-neuroleptic dopamine antagonist. But the side effect is it can cause depression. But it's good. It is good for tardive dyskinesia as well. But if the person is getting depressed or sometimes can get suicidal, then you may have to stop it. SSRIs. So SSRIs are good if there is a OCD and anxiety related, or if there is no OCD or anxiety, but the child is having too much social and occupational impact on their functioning. In that case, you can add on SSRIs to the neuroleptics, or you can give SSRIs if the primary diagnosis is OCD, or if there is a comorbid OCD, then you can add on SSRI. I know it's written on the slide, but I still want to ask you people what dose you will start fluoxetine in a child, in a 7-year-old child, where you know that you have to give him something now, and the tics are so severe, or the depression is so severe that you have to medicate them and nothing else is working. The child is crying all day. What dose of
So
fluoxetine?
we start with low doses. Like in Pakistan, we have syrups available. So we
Yes.
start like 5 milligrams. I mean, usually we give 10, but your slide says 5.
No, what my side, before 5, what is written in my slide?
2.5 to 5.
2.5. And literally, when I was working in the autism service, I started, because autism people, they usually have mild LD as well, and they have smaller brains, and they have different brains than other healthy children. So we started, the lowest started, whenever I started, it was 2.5 milligrams. So let's say 5 ml contains 20 milligrams, 2.5 ml will contain how much? 10 milligrams, yeah? Okay, and then uh,
Yeah.
and then 1.5 I think so 2.5 ml, and then 1.25 ml will contain, I think it will be 2.5 milligrams. And if we go by 0.7 ml, 0.66 ml or something like that, then it will, that will be equivalent to 2.5 milligrams. So we have to give literally, like if it was 5 ml contains uh, 20 milligrams. So the 1 ml will contain about, I think it will be less than 1 milligram or so, or 4 milligrams or so. So you give half an ml, start with half an ml or 0.6 ml or 0.7 ml. Such a low dose you have to start with, especially in smaller children. Any small children start with this dose, and especially with the children with autism or learning disability. And if the children are adolescents, yes, you can, if they're early adolescents, for example, 11, 12, 13, you can start with 5 milligrams, increase it to 10 milligrams. If they are kind of 14, 15 years old, late adolescents, you can start with 10 milligrams and hold it on 10 milligrams for some time. Don't increase to 20 milligrams straight away. So that's the importance of giving so much small doses in any childhood disorder. So whether it's OCD or depression, combination of alpha agonists and SSRIs, or combination of antipsychotics and SSRIs can be tried. And significant, if there are significant tics plus OCD symptoms. What is the difference between tic and obsession compulsion? Question from you. Recap from the last. Anyone? टिक और obsession, टिक और compulsion में क्या फर्क होगा?
Sir, in patient is aware of the fact that he is compelled, but he can still resist it. But sir,
Yeah,
बताना
that's
नहीं है
one.
अपना.
Yeah, that's one difference. And what is the other difference? Ego. What will be the effect of ego of both?
सर ego syntonic आपने बताए थे और
Yes,
ego dystonic. Yes.
yes. And
तो
what is what's
compulsion
meant by ego syntonic?
मतलब कि if a patient has some urge or anything like that तो वो उससे bother नहीं होते, मतलब कि they are okay with that.
They're
But
okay.
अगर कोई yes, लेकिन अगर कोई चीज troublesome लगे और distress cause करे तो that is ego dystonic.
Ego dystonic. ठीक है बेटा. चले. Next. So tricyclic antidepressants, clomipramine. Again, we are talking about OCD. So not for tics only, and not for depression only. If it is depression only, SSRIs are preferable. But if the OCD is so severe, then you may use clomipramine. We have never used in Europe, or especially in Ireland when I was there. We never had to use in children. So usually fluoxetine or sertraline was enough to treat their OCD. But in books it is written benzodiazepines, clonazepam likely to be effective, but because they are addictive, try to avoid them as much as possible. Some studies suggest that they can result in reduction of tics, independent of anxiolytic effects. On their own, without their anxiolytic effects, they can affect positively the tics as well. They can reduce the tics. ADHD medications. Again, if there is ADHD, comorbid ADHD, you have to give the ADHD medications. Now, previously it was deemed that the stimulants will worsen the ADHD, worsen the tics. Now the vision has changed, and they say that they don't worsen. So you can try stimulants as well as non-stimulants in tic disorders. But again, that was in the 6 months where I was working in the autism service. And in that perspective, when I tried methylphenidate in a children with tics related to, it wasn't mere stereotypy because there was urge and there was it was more than stereotypy. So when I tried them on methylphenidate, their tics got worse and the parents were complaining. And when I tried atomoxetine, it was relatively better. But sometimes atomoxetine may also worsen the tics, but generally not. Now the vision is that you can give stimulants and atomoxetine, and there is no harm in giving in comorbid ADHD. Again, the preferable will be clonidine if you can give, because that will be monotherapy and you can treat the symptoms two in one. And other alternatives, so immune therapies, plasmapheresis, corticosteroids, they're all still experimental. Opioid antagonists, naltrexone, and nicotine transdermal patches, baclofen, omega-3 fatty acids, botulinum toxin for very, very severe tics, which are really causing muscle fatigue. In those cases, botulinum toxin may be used. Or if there are any focal dystonia, kind of spasm, if the muscle goes into a spasm, and causes dystonia with abnormal posture, sustained posture. In those cases, you can use these things. And then the surgical treatment, again, it is very much kind of experimental. So stereotactic neurosurgical techniques, capsulotomy, and transcranial magnetic stimulation. It's an exciting potential future treatment for tics. It hasn't been experimented yet, but maybe in the future, because you don't have to make the patient unconscious, unlike the ECT. So it's a non-invasive treatment with near enough, not equivalent, but near enough results as compared to ECT. So and there could be trials in the coming years. Neural stem cell transplantation could have other kind of potential, and pharmacotherapy. So we have just look at the doses, and we'll skip the rest. So haloperidol starting with 0.125 in smaller children, or 0.25 in bigger children. Pimozide 1 milligrams. Risperidone, again, you will start with 0.125, but in adults you can start with 1 milligrams, but in smaller children always start with 0.125, 0. This is the typical kind of, if we go to the starting, like in the middle column, it will give you the starting dose. So haloperidol starting dose is 0.25. Risperidone starting dose will be again 0.25 or even 0.125. Ziprasidone, due to QT prolongations, no more used or less commonly used in Europe. But again, 5 milligrams. Aripiprazole, 1.25 milligrams. So you have to resort to a syrup preparation to go so low. Otherwise, it will be very difficult to divide and redivide the 5 milligram tablets. Clonidine 0.025 milligrams. Guanfacine 10 times higher, so 0.25. Again, tricyclics start with 10 milligrams, not even 25 milligrams, and go up to 25. 25 should be okay for in children with moderate OCD. You don't have to go to 75. So start very low and keep the lowest dose possible in children. Clomipramine, again, you start with 10 and maybe build up to 50. Fluoxetine, 2.5, and even 5 milligrams should be enough, or some in some children, very small children, even 2.5 may be enough. Sertraline 12.5 milligrams, can you imagine? So where kahan 50 milligrams ki tablets or kahan 12.5 milligrams, so one fourth of the 50 milligram tablet. Paroxetine 5 milligrams only, so very much like fluoxetine. Fluoxamine 12, citalopram 2.5, very similar to fluoxetine. Escitalopram also 2.5 milligrams. And the next, again, this is from Oxford, and again, uh, it will give you some the British perspective of the same. So again, the same dose ranges, daily dose. So they are talking about the optimum dose, not the starting dose. But again, it's very small doses, if you can see here. And so these are the references. I consulted the Kaplan and Sadok, and also New Oxford textbook of psychiatry for this. I have already sent these slides to the groups, but if you need it again, send a message in the group and I can resend it. So any questions?
सर आई डोंट थिंक कि अभी किसी ने कोई क्वेश्चन पूछना है.
Okay, we stopped recording then. So thank you very much for listening to the lecture.